Karyotyping definitely you will do, and embryonic factors. So we do PGT to rule out any embryonic aneuploidies. And lifestyle factors also do affect, which can cause implantation failure. After correcting all these things, still there is implantation failure, there comes the role of immunology. So this is what anatomical factors, receptivity factors, thrombophilias, all are being ruled out. And from the embryo also genetic factors have been ruled out. Still my implantation is not happening. Then I will think about immunological causes. So RPL definition, I think you all know this, more than 2 pregnancy losses as per the ESHRE and ASRM. And as the WHO, it is more than 3 pregnancy losses. So actually, the recurrent pregnancy loss, before the first trimester itself, up to 70% of the conceptions will be lost before the end of the first trimester. 85% of the pregnancy losses happen before the clinical diagnosis itself. If you see the picture, almost 60% of the miscarriages will happen in the implantation failure only. So that preclinical losses. Clinical losses we see is only around 15%. So what is the immunological abnormality? Why will this implantation failure and the pregnancy loss happens? So this picture, I would just brief it out. At the end of this lecture, I think we should have a basic brief knowledge. I don't want you to dump everything about immunology, a basic brief knowledge. See, 3 cells are very important. Natural killer cells, Th1, Th2 cells, and T regulatory cells, apart from the B cells, that is autoantibodies. So basically, we all know in the pregnancy, once the implantation happens, the uterine profile should change from Th1 to Th2 cells, because Th1 cells are pro-inflammatory, whereas Th2 cells are anti-inflammatory and helps in embryo implantation. So there should be a change in the Th1 to Th2. And thing is Th17 and T regulatory cells. So Th17 is bad. T regulatory cells are good. So T regulatory cells should be good enough to support the embryo implantation. And NK cells. So there are 2 types, peripheral blood NK cells and uterine NK cells. So uterine NK cells will be CD56 positive, whereas peripheral blood cells will be CD16. So uterine NK cells also plays a major role in implantation and the pregnancy progress. So these 3 cells, T cells, T regulatory cells, Th1, Th2, and the uterine NK cells. Next comes the antibodies, which is one of the very favorite test what we do for majority of us will do, APLAR screening, antibody screening. So here I would like to say that there is a role of anti-TPO antibodies also. So basically we all do karyotyping and APLA. APLA, that is anticardiolipin, lupus anticoagulant, and beta-2 glycoprotein. Very few of us will do anti-TPO antibodies. So there is a study that even the TSH will be normal, so like subclinical hypothyroidism, but TPO antibody positive, landing up in miscarriages, they should be supplemented with Thyronorm, like 25 to 50 based on the body weight. So anti-TPO antibody checking also is equally important in patients with recurrent implantation failure and RPL. So we all know these antibodies will cause thrombosis, affect the implantation and trophoblastic invasion, and it causes. Here I would like to say the immunology is totally different in pregnancy. For a suppose transplant, we are doing a transplant, there we need immunosuppression to accept the outside recipient object. But in pregnancy, it is an immunotolerance. Here the immune system should be activated to accept the embryo. We should not suppress it. So there is a difference between the pregnancy immune system from the transplant thing. So why RF happens? So there is a decrease in the Th2 cells with increase in the Th1 cells. Microbiome, difference in the microbiome. This is a new upcoming era about uterine microbiome. We all know now we are supplementing the patients with oral lactobacillus, because again uterine microbiome also plays in the role for trophoblastic invasion. So these are the few causes for RIF and RPL. And the new concept, when I read this for this presentation, I came through know many things. So 3 things you should remember: HLA matching and KIR. This is not complicated, I will tell you very simple. HLA thing, there are 2 types, class 1 and class 2 antigens. Class 1 antigen is A, B, C, HLA. Class 2 antigen is DP, DQ and DR. Okay. So HLA will be present from the trophoblastic cells. So the fetus will present the HLA. So the maternal uterine NK cells, they will have the receptors called KIR receptors. So these KIR receptors and the HLA, they interact during this implantation period. So what KIR phenotype and what HLA gene is there matters a lot here. So that is a basic concept behind this. So KIR, there are 3 types, A, AB and BB. So AA is very dangerous. It is inhibitory. So KIR-AA with HLA, HLA-C, in that C again C1, C2. C2 is the culprit. So if the fetus presents HLA-C2 and KIR-AA phenotype, there is a high chance of implantation failure and patient will land up in impaired placentation, preeclampsia, IUGR. So we can predict the future of the pregnancy also with the mapping of KIR and HLA mapping. So if KIR-B phenotype from the uterine NK cells is positive, it will support the pregnancy. So simple to remember, KIR-A is inhibitory receptor, so it will not support the pregnancy, whereas KIR-B is more activating receptors and helpful for the pregnancy. Same thing with HLA, C2 is dangerous. So these are the combinations. If you see the maternal uterine NK cells present KIR and the fetus is presenting C2, it is a very deadly combo. The patient will land up in miscarriages. So whereas HLA-C1, KIR-AA, it is neutralizing, so intermediate risk only. If it is KIR-B and HLA-C2, low risk. So we have to see whether fetus is C1 or C2 and the uterine NK cells whether they are KIR-A or B phenotype. That decides the prognosis of our pregnancy. So just remember, KIR-AA is dangerous and fetal HLA-C2 combination is dangerous. This is not very, not experimental. Now we are doing it. We started doing it. So Anderson, few labs like Lifestyle Anderson, they are giving us, it is the blood test, peripheral venous blood test, like how you do karyotyping. This is how the report comes. If you can see there, HLA sharing between the parents they'll give. See, now we have couples, consanguineous, like they want to go for a marriage. That lady's Bava and so she came for the counseling, preconceptional counseling, to know whether is it safe to marry his mother's brother only. Like, so there we can do HLA matching. This is the future. So if the matching between the two is more, like more than 50%, definitely the chances of the prognosis of pregnancy will be bad. So better we can tell them that your matching of HLA is high, better cancel this marriage. So preconceptional counseling for consanguineous marriages definitely helps a role. And patients with RIF and RPL, if you do this HLA matching, it will help us to know what is the similarity of HLA between the mother and father. And again, it will give us maternal HLA-C type. You can see whether C2 or C1. So we can predict the prognosis of the pregnancy. This is how the report looks. So HLA sharing matters a lot. If there is more than 30%, definitely there is a risk of pregnancy failure. More than 55%, definitely yes. So these are the most common problems like uterine NK cell abnormality, TH1, TH2 ratio abnormality, HLA sharing. These are the few common causes for recurrent implantation failure and RPL. So how do we evaluate this? This looks some hi-fi tests and all. How do we evaluate? Routinely you all do karyotyping and routinely we do APLA screening. Now anti-TPO antibody screening, vitamin D, definitely yes you do. Next comes the now recent things like TNF alpha, HLA sharing, KIR genotype and NK cell, uterine NK cell. Like how do we do endometrial biopsy? We can do this uterine NK cell. So if the uterine NK cell percentage is more than 30%, then definitely it is alarming. So NK cell cytotoxicity. So we have to treat this patient. So these are the few tests which we should do to know the immunological cause. So endometrial profiling for uterine NK cells, peripheral blood for HLA and KIR genotype matching. So what are the drugs we have in the market? There are a lot of drugs like aspirin, heparin, steroids, HCQ. So which one to give is the question next. Our favorite heparin and aspirin, definitely we will start if the patient is having a previous history of recurrent pregnancy loss. In spite of being whether APLA positive or APLA negative, but as per the books and evidence, only if it is APLA positive, definitely aspirin and heparin has a role. You all know heparin 40 units. Even for IVF cases, we do regularly give heparin because it has a role in the implantation also, because it acts on the key proteins like metalloproteinases and helps in improving the blastocyst adhesion and implantation. So we do give after the embryo transfer for all the patients aspirin and heparin routinely to improve the implantation. But in RPL cases who are positive for APLA, definitely yes. And aspirin, we all know our favorite drug, definitely we give this because it is anti-inflammatory and anti-thrombotic. The Cochrane review also says that combination of heparin and aspirin improves the live birth rates in patients with APLA and thrombophilias. So combination therapy is more effective than aspirin alone. So please remember, you put the patient both on aspirin and heparin. Heparin 40 units subcutaneous daily. Next comes the steroids. As a fertility specialist, we do give steroids as well. So steroids, either prednisolone 5 mg to 10 mg. 10 mg is what regularly we give. So again, which patients we should give steroids? Yes, definitely if there is altered Th1 to Th2 ratio or increased NK cell cytotoxicity, definitely steroid has a role. So combination therapy, like suppose your patient came to you, in the previous pregnancy she has been given aspirin and heparin, but in spite of that she had a pregnancy loss. Now she came to you with the pregnancy. So add steroid, because combination of prednisolone, aspirin and heparin is helpful compared to, like in a refractory cases, those who are not responding to aspirin and heparin, add steroid. So steroids, again prednisolone 5 to 10 mg is what is recommended. Coming to the IVIG, intravenous immunoglobulins. This is again a costly treatment. IVIG intravenous, it costs around 25,000 rupees, I think. So it reduces again NK cell cytotoxicity and Th1, Th2 balance, improves the complement mediated actions, improves the maternal fetal tolerance. So again there is a study, IVIG in combination with prednisolone and TNF alpha inhibitors. So these are all in refractory cases. So as I mentioned previously, like HLA matching, KIR genotype abnormalities, these kind of patients with a high NK cell cytotoxicity, definitely IVIG will help. So how to give 0.4 grams per kg monthly, started pre-conception. Definitely it has to be given pre-conception, because it will improve the uterine environment, so that it will help in implantation or in early pregnancy. So 5 days before ET we definitely give, and can be given at UPT positive and to be continued every 3 to 4 weeks till 12 to 20 weeks of gestation, because it modulates the NK cell cytotoxicity. Some studies have tried GCSF also, because it improves the endometrial receptivity and enhances the implantation. Next, intralipid. This is my favorite, though the evidence does not support intralipid, but compared to IVIG, intralipids are cheaper. So I use intralipids in my routine practice. So intralipids, 100 ml intralipid in 500 ml of normal saline. We give it over 2 hours on the day of starting progesterone. That means 5 days before the embryo transfer. And once the pregnancy is confirmed, we can continue that till 12 to 20 weeks of gestation. Again, the mechanism of action is same. It modulates the NK cell activity and improves the Th1, Th2 cytokine balance. It can also be used in KR and HLA related RPL also. Next, the other most common now recent drug is tacrolimus. Any conference if I go now, people are talking about LIT therapy and tacrolimus. So what is this tacrolimus? It has to be given only under the supervision of a transplant physician. Don't give it individually. Tacrolimus, the minimum dosage is 1 milligram per day. It is a calcium urine inhibitor. Again, it causes Th1, Th2 imbalance will be corrected, and it improves the KLA and HLA signaling pathway. So because its side effects like nephrotoxicity and maternal hypertension, we have to keep in mind and continue it only up to 12 to 14 weeks. Again, I am telling you, these are all drugs only when the patient is having a normal uterus with a euploid embryo and patient wants to go for self gametes. If the patient is willing to go for donor gametes, there is no role for LIT, there is no role for IVIG, nothing. So whether the patient wants to, see, actually patients will come frustrated, 3 times IVF failure, I am planning to go for donor gametes. Then there is no role for immunology therapy. Only if the patient wants to go for self gametes, then comes the role of HLA matching, KIR genotyping and all this immunomodulated treatment. So next thing is TNF alpha inhibitors like etanercept and adalimumab. These are still experimental, not routinely used, but again they can be used in elevated TNF alpha. Now there is a blood test which will tell TNF alpha. If it is elevated TNF alpha, straight away these cases can benefit from TNF alpha inhibitors. Next, HCQ. HCQ is also one of my favorite drug because we can give safely throughout the pregnancy also. So especially in RIF cases, we start it 2 months prior to the embryo transfer itself. It has to be given at least 2 months prior. Then HCQ, again, it is it has autoantibody, reduces the autoantibody activation, useful in high NK cells, useful in refractory cases of APLA also. So along with your aspirin and heparin, we can use HCQ safely. 200 milligram twice a day is the recommended dose. Next is LIT. So any conference, if you go now, fertility conference, they talk about LIT. What is this LIT? It is a lymphocyte immunotherapy. So basically what happens is when the mother, this embryo is a semi-allogenic graft because 50% of the genes will be from the father. So mother has to recognize these antigens and it will form the blocking antibodies. So if the mother is deficient in these blocking antibodies, the chance of rejection of the embryo will be high. So there is something called CDC testing. CDC testing is cross-matching. So whether the mother is positive for blocking antibodies or not, there is a test. So if the mother is negative for blocking antibodies, that means it didn't recognize the paternal antigens. Then comes the role of LIT. So you give the lymphocyte immunization therapy of the paternal antigens. Then mother will start forming the blocking antibodies. The chance of pregnancy acceptance will be better. So every patient does not need LIT therapy. Only those who are blocking antibody negative, those kind of patients, LIT will help. LIT, again, it is prepared from the father's blood. 80 ml of blood will be taken and it will be centrifuged. Only the lymphocytes will be injected either intradermal or subcutaneous. And now other favorite drug, I think many of you might be knowing thymosin alpha. Thymosin alpha, the evidence of thymosin alpha in RIF is there, but it's still in RPL, still more studies are to be yet to come. So thymosin alpha in RIF cases, they are recommending it like from day 0, every alternate days till 2 days before the embryo transfer we are giving. Once the test is positive, we can still continue it twice weekly dosing for the 3 months, that is up to 12 weeks. So thymosin alpha is the new drug again in the market. There are a few studies which have positively supported this in RIF cases. In RPL cases, still we have to get more information. So after all these things, which immunomodulators? Now you are confused which immunomodulator I should use, either aspirin, heparin, steroid, LIT, IVIG. So yeah, see, if it is autoimmune cause, definitely aspirin, heparin, HCQ, steroids. Don't put all these things in first straight away. If the patient does not respond to your aspirin and heparin, in the next pregnancy, definitely you add HCQ or steroid. Definitely it will helpful. KIR and HLA signaling. As I said previously that we will get the report which is HLA C1 or C2 and KIR. These kind of cases will benefit from IVIG, tacrolimus and intralipids. Consider intralipids because it is cheaper. If still the patient is having recurrent pregnancy or recurrent implantation, then add IVIG or tacrolimus. So I told you LIT should be considered only when the CDC cross-match test. If it is positive, there is no role for LIT. That means already the mother is positive for blocking antibodies. So there is a test called CDC cross-match test. Okay, so I would like just conclude my slides with 2 scenarios which we have managed. This is a lady who is anti-Rho antibody positive. So she is already under regular care with a rheumatologist. She came to me for IVF. So then we have continued the HCQ and low-dose steroid. After the pickup, once the pregnancy was positive, only on HCQ we could drag it, and every early TIFA scan, fetal echo was done to rule out the heart blocks. By God's grace, she was under completely control. So live healthy girl baby was, she delivered a healthy baby. Throughout the pregnancy, we have given only aspirin and heparin and HCQ. Steroids were given prior to the pregnancy. Just because the steroid was, pregnancy was positive, the steroid dose was tapered and there was no flare-up. Another patient, now patient is undergoing surrogacy. Actually, she is a SLE lupus nephritis positive. She is hypertensive, obese, previous history of 2 abortions, 5th month, preeclampsia. So the nephrologist said that there is a chance of flare-up, so better not to carry the pregnancy. So we counsel her for surrogacy. And then now we are going ahead with surrogacy. So here I would like to say in the future what is going to happen is sperm donors also we might select based on the HLA. If he is HLA C2 positive, we won't take them as a donor because we want HLA C1. Even in the surrogates also in future, maybe we will do KIR matching. If the KIR is AA, she is not eligible to act as a surrogate. So in future, these are the immunological tests which are going to come up. But again, I conclude my talk telling that these are all fancy things in the market. First thing is rule out the normal causes for implantation failure like any sperm DFI, lifestyle factors, euploid embryos, genetic factors. After all this correction only, then comes the role of immunology. So immunology will not take away the entire thing. First thing is normal things have to be ruled out. So normal pelvis, suppose if she is having grade 3 stage 4 endometriosis and adenomyosis, that is the cause for implantation failure. There is no role for LIT in that kind of patients. So first thing is we have to rule out the other causes, then comes the role of immunology. Thank you so much.